having me attend this virtually conference, and I'm so honored to be here. I am Ebtsam Islam, Associate Dean of Clinical Medicine at Texas Tech University Health Science Center, and I'm going to be talking about lung cancer screening program and the 2021 USPTSF recommendations. So the recommendation just came out in March of this year. Inshallah, I hope soon that I can be in Mosque to give these talks in person and meet all these lovely people that are attending these conferences, inshallah. So, excuse me. So I have no financial conflicts of interest. So objectives today, we're going to discuss, I'll go over a case that we used for the lung cancer screening, the recommendations, and the screening process, the harms and benefits of that, and then what the actual screening program entails. It's not just doing CT scans, but it does kind of have a lot of other things with it. So here we have a 69-year-old African-American male who had no significant past medical history that presented to our lung cancer clinic for screening. No surgical history, no past medical history, family history, no non-contributory. He did smoke 2 packs per day for 50 years, but did quit in 2013. Review of systems was negative. His physical exam was within normal limits. And so patient ended up qualifying for a low-dose CT scan of the chest. So this is his first low-dose CT scan that he got done while he was in our clinic, and this was in 2019. And you can see the red arrow here pointing to a very, very small lung nodule that we discussed together, and we decided that it would be best to wait to get that biopsy because it was just very small, and so the likelihood of us getting it was not going to be very high. So he came in follow-up in 1 year with his yearly low-dose CT scan. Again, no complaints, no weight loss, no hemoptysis, and so he was going to do his chest CT scan in 2020. And so that same nodule had grown over 1 year, and you can see here from his second year of his low-dose CT scan that he had received. So we discussed together again, and so it was decided that the patient would need to get a biopsy. So we took him back to the bronch suite. We performed EBUS bronch and navigation so that we could A, get samples, and B, get staging while we're at it. So he was biopsied station 11L, 4L, and 7, and the nodule came back benign on lung tissue. Well, if it looks like cancer and smells like cancer, I don't stop there. So we sent him to interventional radiology, and the patient then got CT-guided IR biopsy of the left upper lobe nodule. And sometimes these nodules are harder to reach with navigation, and so if you have a high suspicion that this is still cancer, don't stop there. Find a way to get the nodule biopsied some other way. So sure enough, his pathology came back small cell carcinoma. So on his PET CT scan, you can see that it lit up there. So PET avid. And so what we did was, since his lymph nodes were negative from EBUS, and that was the only nodule that we had there from the PET scan that lit up, no other areas, the patient was actually referred to cardiothoracic surgery. And as many of you know, a lot of times when we find small cell cancer, it's already metastasized everywhere. And so this is not always an option for these patients. Patient received the left thoracotomy with left upper lobe lobectomy and mediastinal lymph node dissection. So the pathology from surgery, he had the left upper lobe lobectomy, showed small cell carcinoma, 8 lymph nodes with anthracotic pigments that were negative for metastatic disease. Station 5 and station 10L were both negative as well. So because of the lung cancer screening program that this man participated in, we were able to catch his small cell at a very early stage, early enough that he was able to get surgery. So this can definitely be a life-saving measure. Okay, so the 2021 U.S. Preventative Services Task Force recommendation statement. So asymptomatic smokers and former smokers aged 50 to 80 years old are the ones to be screened. So previously it was 55 to 77 years old. Those patients that smoked 20 pack years as opposed to 30 or more and either continue to smoke or have quit within past 15 years are also recommended to get screened. So instead of having more pack years of smoking, it's recommended that it's within a smaller frame. And if those patients are asymptomatic, absences of symptoms that suggest the presence of lung cancer. So they need to not have these symptoms present in order to be part of the lung cancer screening. And these recommendations are from the JAMA 2021 from March of this year. Okay, so the risks, why these changes were made. So African American Black men have a higher incidence of lung cancer than white men. Black women have lower incidence than white women. There's increased secondary to smoking exposures, exposure to carcinogens and cigarettes, and there's also social risk factors that contribute to lung cancer. So also environmental exposures can contribute to risk factors, prior radiation therapy. Other non-cancerous lung diseases can be risk factors. If there's a family history, such as a brother, blood-related that has a lung cancer, that can definitely contribute to that. And it's also found that these patients have a lower level of education do have higher risk factors. So the recommendation is to use age and smoking history to determine screening eligibility instead of elaborate risk prediction models. There's insufficient evidence if risk prediction models based screening would actually improve outcomes. So you want to use age and smoking and history as predominantly what you're doing to screen these patients. So screening tests. You want to use the low dose CAT scan. Has a high sensitivity, reasonable specificity. What is not recommended and is not found to be beneficial is sputum cytology, chest radiography, and measurement of biomarker levels. So again, you want to do the low dose CT annually. So benefits, mortality reduction, obviously due to earlier disease detection, such as in the patient example that I presented. And then the other part is you're taking a multidisciplinary approach. So your oncologist is involved, your radiologist is involved, your pathologist is involved. So and radiation oncology. And so we have monthly tumor boards where we are discussing these patients and going from there. Other benefits is you have favorable impact on smoking cessation rate. And then therapy is more effective in early stage disease. And so therefore you can increase the overall cure rate and more limited surgical resection. Harms, so abnormal findings can lead to needle biopsy or surgery. Among abnormal results, 96% can have false positives, no diagnosis of lung cancer, 11% of positive results to lead to an invasive study, and then 40% of incidental findings of emphysema or coronary calcification. So when you're just doing a scan, you know, you're not just looking for the lung nodules, but you're going to get everything else that comes with it. So radiation exposure increased risk of cancers, 1 in 108, one major induced cancer. However, the idea is using the low dose CAT scan radiation dose of 1.4 versus 7 to 8 reduces that risk for the standard CAT scan in comparison to the standard CAT scan. The other harms, of course, can be patient distress. So if you're just following the nodule and it just kind of stays small and you can't really do any intervention, this can be very distressing to patients that I'm living with the possibility of a cancer, but I don't know for sure. And also short-term psychological discomfort, but did not affect distress, worry, or health-related quality of life. The other part of the harms for the screening program is overdiagnosis. So identifying cancers at screening that would not have affected morbidity and mortality if it had never been found. And then after 6.5 years, 119 more lung cancer identified in the low dose CT group as compared with chest x-ray. So what's really important here is as part of the lung cancer screening program is smoking cessation counseling. And all persons do receive smoking cessation in our clinic, and they should receive it with cessation interventions such as medications, patches, in order to help them to quit smoking. If these patients are referred from primary care physicians, they should have already received smoking cessation with the referral. but it is really essential that it be incorporated into the screening program. Shared decision-making is definitely an important part of the lung cancer screening, and this occurs between the clinicians and patients. And so it obviously varies with risk. Those at higher risk are more likely to benefit. It is a reminder that screening does not prevent most lung deaths, but smoking cessation can help with that. And, you know, there's potential to cause harm. So in discussion with patients before they even get the CT scan, we discuss if we find something that, you know, interventions will likely be necessary to do biopsies. If that's large enough, if something's a little bit smaller, but we're going to continue to watch that nodule, then that will continue kind of throughout the years. And so the idea of living with a lung lesion, patients need to be aware of overdiagnosis and the risks of radiation exposure with the low dose CT. But also you're discussing the benefits and limitations and harms of going through the screening program. So standardization of the low dose CT screening and follow-up of normal findings. So the American College of Radiology developed the LUNG-RADS grading system, and this stands for Lung Imaging Reporting and Data System. And this was to minimize the uncertainty and variation about evaluation and management of lung nodules. And this also standardized the reporting of the low-dose CT screening results. So on all my low-dose CT screening reports, of course, I always look at all the images myself and make the final decision, but the radiologist will write LUNG-RADS 1, 2, annual screening in 1 year. And so they make their recommendations based on what they are trained from the American College of Radiation. And this gives guidance to clinicians which findings may be suspicious for cancer, and also possible suggested management of lung nodules detected. And the hope is that this may decrease the rate of false positive results. So in summary, the 2021 U.S. Preventative Services Task Force, the recommendation statement is to screen for asymptomatic smokers. So a reminder, no hemoptysis, no signs of cancer already, and former smokers aged 50 to 80 years old. So we've broadened the range here of the patients that were being screened. And patients that smoke 20 pack years or more and either continue to smoke or have quit within the past 15 years. Now, again, the patients need to be asymptomatic in order that they're not already concerned that they may have a cancer already. And usually screening continues until 15 years out after that patient has stopped smoking. So those are the 2021 recommendations for the lung cancer screening. Thank you. And I apologize, I will not be able to attend the live. So if you have any questions, please send me a message. I'm happy to answer or email, and I appreciate your time. Thank you.